Welcome to PharmaDocs with your host, myself, Dr. J. Reznick, and Dr. John Roberson. Practicing oral surgeons bring you the latest and greatest in pharmacology as it affects you in your daily dental practice. All right, good evening, everybody. I'm Dr. J. Reznick, and I am coming to you from Los Angeles, California. And my friend and colleague, John Roberson, is in Hattiesburg, Mississippi.
Good evening.
And we are bringing you our new podcast, or actually it's technically a webcast because you can see us, called PharmaDocs. And John, you want to talk about, explain how we came up with this idea?
Oh, absolutely, Jay. And thank you for everybody turning into us tonight. We're really excited about PharmaDocs. And, Jay and I are both national lecturers. We talk on various subjects. Over the last year, I've been talking about strictly medical emergency preparedness with some pharmacology. And I just kept getting question after question, like, where can I find some great lectures just on pharmacology? Because a lot of the material, Jay, that I was introducing, people just did not know what these new drugs were. So I went to you and you so graciously said, look, let's work on this. Come up with something for our practicing dentists out there, because you and I are just like them. We're out in the trenches every day in that daily grind. We're seeing all these medically compromised patients.
They seem to be attracted to my office.
There's just a slew of new drugs coming out on a continual basis. How does one keep up, Jay?
About 50 new drugs are introduced or approved by the FDA every single year, right?
That's correct.
I've been out of training for 26 years. So that's 1,300 new drugs since I've started practice. How do you keep up with all that?
What kind of adverse drug reactions could you have from that?
Patients come into my office. Patients come into my office all the time with drugs I've never heard of before, because there are so many new drugs, and I don't watch a whole lot of TV or listen to the radio, so I don't hear all the ads for these new medications. But there's so many of them out there, and like you said, these drugs have a significant effect, or can have a significant effect on our patients, because first of all, depending on what they're on, that gives you a clue as far as their medical history goes, how severe they are. If they're on a couple medications for their asthma, they're at higher risk of having an asthmatic attack while they're in your treatment. Or if they have diabetes and they're on, let's say, 2 different hypoglycemics, that patient is at higher risk of getting infections, because it's harder to control their diabetes. And you got to know these things when the patients come in, as well as, when the patient writes down their medications. You don't want to walk into the room with the patient and sound like you don't know what these drugs are. Luckily, we have Hippocrates and Medscape. I can look them up real quickly if I haven't heard of it. Or I'm not completely familiar. So we have that advantage now, which we didn't have, 10 years ago, or maybe a little longer. But when we see our patients and we see them for a consult, we've got to be up on the drugs that they're taking. And that's kind of why we're here, is to bring you up to date on new drugs that have been released, maybe some little tidbits here and there, some things, some anecdotes from our practices and other things to keep you entertained.
Well, Jay, what you just brought up is like, okay, so all of us listening, all of us practicing every day, we have to be worried about adverse drug reactions. Medically compromised patients on multiple medications.
Multiple medications.
I mean, we're talking that no longer do they bring the paper bag in there. They've gotten sophisticated. They come in with spreadsheets and Tupperware now. All right. So we got that. And then we're overwhelmed with brand new drugs being approved. So Jay, those 4 items right there are concerning to all of us out there practicing, because of the 5th unknown, a life-threatening medical emergency.
And that's, you don't want to have that in your office. It definitely ruins your day.
And it can ruin your life. It can take away your practice. All right. So we got to know pharmacology and we got to know medical emergencies. So like you said, we're going to bring tidbits of a little bit here and there, talk about some new drugs. But just to go back to what you said, I want the audience to hear me. I counted the new drugs, 2018, 59, 2019, 48. 2020, 53. And Jay, get ready for this. As of
Drum roll.
today for 2021,
Uh-huh.
73 new drugs have
Really?
been approved.
And we still have 2 months left in the year.
Yes.
Wow.
73. How do you keep up, Jay?
You can't. But that's why we're here, is to try to bring you up to date on these new drugs that have a relationship to your practice of dentistry in your daily practice. So how these drugs may, give you some clue as to how healthy your patient really is. But more importantly, we are prescribing drugs every day. We're prescribing antibiotics. We're prescribing opioids. We're prescribing other pain medications, non-steroidal anti-inflammatory drugs. We're giving local anesthetic. Some of us are sedating patients, and all these drugs that we're giving a patient can have severe interactions with medications the patient may be taking already.
Right.
So,
Jay, don't forget about the local anesthetics, like you said, with a vasoconstrictor. So we got epinephrine in there, that we have to be concerned about. Okay.
Yeah. I mean, luckily the epinephrine's there to keep the local anesthetic and the epi from disseminating into the bloodstream too quickly. So it's a slower release. But yeah, some patients are very sensitive to epinephrine. You're talking about how patients can be on multiple medicines that you haven't heard of. I had a patient come into my office last week. She had breast cancer surgery in December of this year. She had an angioplasty in September of this year. And she's allergic to penicillin and codeine. She gets a rash from both. Her medication list. Okay, ready to go through this? Letrozole. Letrozole. Do you know what that is? Okay, it's for breast cancer, for HR positive breast cancer. She's also on Repatha. You know that one?
Yeah.
Yep. That is cholesterol lowering medication. She's on paroxetine, which otherwise is known as Paxil. So you may not know the generic name, but certainly we know that Paxil is an SSRI, a selective serotonin reuptake inhibitor. Right. And some of the medications that we may prescribe, in fact, one we're going to talk about today, interact with the metabolism of SSRIs and can lead to a significant medical problem. She's also on clopidogrel, which is also Plavix and Clopid. Getting tongue-tied here. And those are both anticoagulants. And I don't know about you, but when I've had patients on Plavix, they bleed so much more than a patient who's on warfarin.
Oh yeah. Or one on
their blood's like water.
Yes. Yeah. Or Xarelto.
Yeah.
But I mean, those are just a few. We still have Effient, Brilinta, so many other, and we'll talk about all these blood thinners in upcoming shows and all that. Spend some times on the new anticoagulants as well.
Yeah. But it just goes to show, that patients are on multiple medications that we really need to be aware of when we're seeing our patients. So really when the patient comes in with their medical history, you want to look up, if you don't know the medication they're on, look everything up and write a note in the chart so that you know what it is.
And you want to do that before you walk into the room.
Yeah, exactly.
Yeah. So
exactly.
But Jay, okay, so telling our audience more about just the significance about adverse drug reactions. I mean, it's the fourth leading cause of death in our country.
Mm-hmm. Yeah.
I mean, it's seen greater in patients with diabetes or pulmonary issues, chronic alcoholics.
Yeah. The more diseases they have, the more medications they're going to be on, the more brittle they are.
Oh, absolutely. Yeah. And one of the things we're talking about, like in my medical emergency lectures, I do a section on patient red flags, and all that we're talking about, patients on multiple medications for one disease state, that's a red flag.
Yeah. Oh, right?
Yeah. That's just automatic. But they estimate over 2 million adverse drug reactions a year with about 100,000 deaths.
Wow. Those are significant numbers.
Could we be a contributory factor to that by the drug we prescribe? Because, it's just an analgesic. It's not going to interact with anything. Right. All right.
Yeah. We very well could be.
Tonight, that's going to be different.
And hopefully this webcast will give you information and tools to as much as possible, prevent these medical emergencies from occurring in your office when it comes
Absolutely.
to drug interactions.
And, I like to talk about mnemonics all the time. And so, something like, um, you have all these multiple medications besides the ones that we prescribe. Those are prescription pharmaceuticals. Okay. You got over-the-counter drugs.
Mm-hmm.
You got herbals.
Yeah. Herbals.
You got supplements.
Yeah.
You've got vitamins. So, tonight on the show, we could call it Pharma Shove, SHOV.
Yeah.
Supplements, herbals, over the counter, and vitamins. Okay.
So I like that.
How you like that? So,
I mean, but the thing is that patients usually or very rarely tell you that they're on these herbal medications.
57%, Jay.
Yeah.
Don't tell us what all they're
And
taking.
some of these can have really significant effects. I mean, just take as an example, Coumadin. It's affected by garlic, devil's claw. I don't think I'd ever want to take that. Ginseng sounds painful. Green tea, St. John's wort can affect the metabolism of Coumadin and raise the PT and INR. And then there are foods that can do the same thing. Grapefruit inhibits the breakdown of Coumadin. And here's one I didn't know. Broccoli and Brussels sprouts are dangerous vegetables if you're on Coumadin.
Yes.
Yeah. So it just goes to show you got to know everything that goes into that patient's body.
That's right. And you got to be able to have that source to go back to, like, okay, what's going on? Why is broccoli or kale? Okay. Why is that an issue on somebody on a blood thinner right there too? Mm-hmm. So let's don't forget about our elderly population as well too, Jay, because like in the nursing homes, there's over 350,000 adverse reactions every year.
Yeah.
Okay. And, remember, our elderly are, they have a slower metabolism, slower excretion,
right?
Multiple medications,
right? Much higher risk.
Much higher risk. That's a high risk patient all the way around.
Yeah.
And then, of course, then we get into, like you said earlier, about increased drug combinations, local anesthetics, sedatives, narcotics. And then with medically compromised patients, Jay, they either have one disease, multiple disease, or they could be a combination diabetic, hypertension, stroke, dialysis, lots of medications, and we have to be careful.
Yeah, a lot of medications.
And then look, let's don't forget about the other one, non-compliance. I mean, you got inflation going on right now. What do people typically do? They cut back on their medications, take half a pill.
Yep.
That's the reason why
I'm
they go without. Advocate of blood pressure
without.
In the office.
Yep. Yeah, we take everyone who goes into surgery gets vitals before, during, and
Jay,
after.
I want to give. I'm going to call our group listening to us the Pharma Nation. Okay.
Oh, I like that.
Yeah, how you like that? So
we'll have to get T-shirts.
Let's do it. All right, now.
All right. So why don't we start talking about the because we want to keep our webcast between 15 and 20 minutes every day because we John and I have short attention spans. So we want to, and we know that a lot of you have busy evenings. So we're going to try to keep this broadcast to 15 to 20 minutes every night or and by the way, we're going to be coming to you on the second and fourth Thursdays of every month at 5 p.m. Pacific time. And that's 8 o'clock on the East Coast. So the first medication we want to talk about is something called Zimhi. And John?
Well, first of all, anybody out there know what it is? All right, we just asked you. All right.
Yeah.
Do you know what
Zimhi is? It's something that's already on the market.
Yes.
It's something that you've probably used in your office or a family member may have used.
Correct. Okay, drum roll.
It
Zimhi is
I think it's woke up by dogs. But it's in a more concentrated form. So regular naloxone, I think, is 1 milligram per cc. This is 5 milligrams in a half cc.
Right. So and our dosing on that is like 0.4 milligram to 2 milligram. And of course, you got Narcan,
regular naloxone.
Nasal spray, which is 4 milligram.
Yeah.
Okay.
Yeah. And these drugs are metabolized fairly rapidly. In an hour, 1 to 2 hours. And of course, naloxone is used for reversing opiates.
Correct.
And, it's a very popular thing these days because there's so many people addicted to opiates that family members are being urged to have naloxone with them and even people who have are using the drugs to have naloxone with them in case they feel like they're overdosing. And
Jay, guess how many people died last year in America of an opiate overdose, narcotic overdose?
Far too many.
93,000
Wow.
people. Okay.
Wow.
And think about it. With everybody staying home at COVID, depression setting in.
Oh, yeah.
Increased use of drugs.
Yep.
So the FDA approved this because they felt like, with other doses of naloxone out there right now, that it was inadequate and frequent redosing. So they bumped it up to 5 milligrams.
Yeah.
Now this comes in a single
Pre-filled
device.
syringe, right?
It's a single dose pre-filled syringe. Okay. All right.
And it's single use, and you jab it into the patient's thigh, either a subcutaneous or an intramuscular injection.
Yes. Now, to the nation out there, actually, Jay, another drug was approved this year that was also a naloxone drug as well. Anybody want to take a guess? Well, it's called Cloxado. All right. Cloxado. All right.
Okay.
It's a Narcan 8 milligram nasal spray. It was approved in April.
Okay. Of this year.
So like when you can buy Narcan 4 milligram, which comes with 2 spray units in the box. This comes with 2 8 milligram units. Now, when you take it out, do not prime it. You just lost your naloxone. Okay. So that's not a good time to practice. Okay.
Okay. Yeah.
All right. So that's one thing I always tell. Now, if it goes out of date, that's a great time for you and your staff to get together. Here's how we use this. Okay.
Yeah.
All right.
Yeah.
And never, Jay, give an expired drug. And we'll talk about that another time.
Yeah. Okay. So the other new drug we're going to talk about is Celentus. And this is a combination drug of 2 drugs that we have been using in our practices for many, many years. So it's celecoxib, which is Celebrex, and tramadol. And the combination of those 2, as you know, combination drugs of a narcotic, and tramadol is a sort of a synthetic narcotic. It has a much lower addiction potential. And that's why I prefer to use it over hydrocodone, is that you combine that with a nonsteroidal anti-inflammatory, and you've got a really great drug, and you're able to use lower doses of each one. So the celecoxib, the Celebrex, the normal dose for that is 200 milligrams twice a day. The tramadol is 50 milligrams to 100 milligrams every 4 to 6 hours. With Celentus, it's a timed release, so it's a twice a day dosing.
Well, I just love drugs like this because, again, this helps us as practicing dentists every day to reduce the chance of a stronger narcotic.
Yeah.
Like you said, to the pharma nation out there, do you know which opioid receptor this affects? It's the mu receptor. All right. So there's 4 opiate receptors. This only affects 1 receptor. So it's a very low dose narcotic for us to prescribe. And I like the fact that acetacoxib being a selective COX-2 inhibitor, because remember, the COX-1 inhibitor also affects our GI. So
tract.
That's the issue why we have problems there.
Yeah.
That's why they came up with the COX-2 inhibitors right there.
Yeah.
Because of the gastric cytoprotection properties.
Right. Yeah, there were some issues with some of these COX-2 inhibitors when they first came out of MI and strokes. And it took a little while to figure out what was going on. And it seemed, that even though it's a selective COX-2 inhibitor, it does have some COX-1 activity. And what was happening, it was inhibiting thromboxane, which it was reducing the breakdown of thromboxane, which is released from platelets in the bloodstream, and so it was leading to blood clots. And that was the etiology of that. And I think a lot of black box warnings were put on these drugs, And especially, this is nice because it's at a much lower dose too. It's not 200 milligrams twice a day. It's 44 milligrams twice a day.
Well, and those drugs back then were Bextra and Duract.
Yeah.
And Vioxx.
Yeah.
I thought they were great drugs, but for everybody out there, remember, we're going to be writing these drugs for short-term use only. Okay.
Yeah.
So we're not looking at long-term use right there as well. But
Yeah.
Jay, with it being tramadol right there, our listeners need to know that there can be some significant interactions with certain drugs.
Yeah. And the big one with tramadol is its interaction with antidepressants.
Correct.
The tramadol increases serotonin levels. That's one of the mechanisms that it uses to reduce pain. And of course, the antidepressants are serotonin release reuptake inhibitors. So they increase the amount of serotonin at the nerve endings and at the synapses. And so when you combine a non-steroidal anti-inflammatory, when you combine the tramadol with an antidepressant, you can really significantly raise the level of serotonin and get what's called serotonin syndrome. And that's something that's not pretty. Patient will get increased heart rate, blood pressure, they can get very jittery, fever, they malaise, they can exactly, it can actually be fatal. So you want to know if a patient is on an SSRI, and a lot of patients are on SSRIs these days, you don't want to give them this drug.
Or Jay, the other one is the Mao inhibitors.
Yeah.
Okay. So one thing I like to talk about in my lectures also when I talk about tramadol is, I show a slide. I said, what are these two drugs? And the names are Azilect and Zadago. What a cool name, Zadago. Okay. All right. And I said, what happens if you prescribe it with tramadol? Well, nobody knows what those two drugs are. Those are MAO inhibitors. Okay. All right.
They're not used as much anymore, but they still are used.
Yeah. They're having a resurgence now, Jay. They're back on the market. People are using them. So we got to be aware of this because we don't want to write tramadol with them.
Yeah.
We sure don't want to write cyclobenzaprine, also known as Flexeril, and we don't want to write Demerol, meperidine with those. Okay. So what you're talking about, the serotonin syndrome. All right.
Yeah. Exactly.
We can have an adverse reaction, and we wanted to share the signs and symptoms with you in case you make that mistake and you prescribe that drug and they're on these drugs and you get a phone call that night from a spouse or a loved one saying, hey, look, our patient's not doing well. Her heart is beating very fast. Her blood pressure's out of control.
Yeah, she's sweating. She's got diarrhea. Yeah,
that's right.
Exactly. That serotonin syndrome should jump into your mind, and that patient needs to go immediately to the hospital, where they can give them a drug called cyproheptadine, and that'll reverse the serotonin, bring the serotonin level back down. So great
point right there, Jay. Yeah. Great point.
Yeah, that's a true medical emergency. Yes. So we're actually been talking for 23 minutes already, and we've talked about two new drugs that will soon be released that have an effect on your daily dental practice. And again, another take-home message, in addition to know the medications your patient is on and know what the interactions and side effects are, is to make sure that if you don't know what a medication is when you see it on the patient's health history, to look it up and know what it is before you go in and see your patient.
And like you just said, Jay, these two drugs are to be released soon. They've been approved. And you would just need to check with your pharmacy, are they available? And like Jay and I have both said, Pharma Nation, we like these drugs. Okay. Zimhi is a good drug to have because that same company, Jay, makes another drug we like to use called Simjepi. That's an epinephrine auto-injector. So two great drugs for medical emergencies that could happen in our dental offices.
Yeah.
And we have to
especially if you use any kind of sedation.
That's right.
And you overdose the patient.
And the other thing is we love Celentus. What a great combination. We're just telling you drugs you need to be cognizant about on your patient profile in their chart. You've got to know these medications. Can I write Celentus for this patient?
Yep. All right. So that's about all the time we have. So we just want to remind you again that we will be coming to you at 5 p.m. Pacific, 8 p.m. Eastern on the 2nd and 4th Thursday evening of every month, and we hope to see you at our next in our next broadcast, and that's going to be on November 11th on Veterans Day.
Now,
So we
Jay,
hope to see you then.
I'm gonna leave Pharma Nation with another one of my little catchphrase.
All right,
We're
let's
gonna
hear
call it the Pharma 6P. Proficiency in pharmacology prevents patient prescribing pitfalls.
I like that.
How you like that, Jay?
All right. Well, with that, we're going to both say good night. And
thank you,
have
listeners,
a good
for
Friday
being here.
and rest of the week, and we'll see you on November 11th.
Good night, everybody.
All right. Night.